Welcome everybody to our August TASC 90. Our topic today is maternal health and in the context of flex programs. Completely struggling. All right, there we go. Maternal care strategies for state flex programs. Thank you for joining us. The learning objectives with this webinar is that by participating in it, participants will be able to recognize the challenges critical access hospitals face in providing maternal care services to rural communities, identify strategies the industry is taking to bridge the gap in coverage of maternal care services, and assemble maternal health resources available to provide enhanced support for CAHs with and without birth units. Our agenda for today includes our standard Flex Partners updates. And then we have Dr. Dillon talking from the Federal Office of Rural Health Policy about maternal health. We'll have some group discussion toward the end with some questions and answers, and then we'll also do some after educational content polling questions that we always do. So with that, I will turn it over to Laura Seifert from the Federal Office of Rural Health Policy.
Hello, everyone. I'm going to give a couple of quick updates. These are all things that you all just heard about last week in our end of year wrap-up webinar. But with the end of a program year, we have a lot of due dates that are coming up, and it's a lot of paperwork. And I know that is everybody's least favorite thing, but they are important things that we have to take care of. So you're going to get a lot of emails coming with more links and resources and templates and instructions on all of this. But as a reminder, your PIMS report is due into Salesforce at the end of October. And then your federal financial report is due November 29th. Your EMS supplement final report and your regular end of year report is due at the end of November 30th. And 30 days after your federal financial report is due, your carryover is due at the end of December. Your federal financial report and your carryover request, those are hard deadlines. We cannot grant extensions for those. So please, please, please keep those in mind. Again, I'm going to send out some more information with more templates and instructions as everything goes, and we get links posted into the TASC website. But just keep that in mind. And I just got word our policy person just joined us, Lindsay. So I'm going to kick it over to Lindsay for a quick policy update.
Everybody, my name is Lindsay. I am a public health analyst in the Policy Research Division. So Courtney is unable to be here today, so I'm just going to go through some of our policy updates, and we will also send this out afterward with some additional details. So if you miss anything, just let me know if you want me to repeat or wait for the after report. But so I wanted to talk a little bit about the inpatient prospective payment system final rule. And so the CMS released that final rule for fiscal year 25. And it will be effective October 1st. CMS will use OMB 2023 guidance, which it's based on the 2020 census to define labor markets. So as a result of OMB's redesignation, some rural areas are going to now be urban. For CAHs in these areas, they will have 2 years from October 1st to reclassify as rural. SCHs and MDHs need to reclassify by October 1st to avoid disruption in payment. Other rural relevant policies in the IPPS final rule include extending the low wage index adjustment, providing a separate payment to small independent IPPS hospitals who choose to establish and maintain a buffer stock of essential medicines for use during future shortages, distributing an additional 200 Medicare funded residency payment slots to train physicians per statute, adjusting hospital payments when patients have inadequate housing and housing instability, and extending certain COVID-19 and influenza data reporting requirements for hospitals and CAHs. CMS did not finalize a proposal to define new in the context of residency training programs, and they're going to continue to collect comments on the issue. The combination of all the policies finalized for FY25 is estimated to increase IPPS payment rates by 2.9% for hospitals that successfully report quality measures and are meaningful electronic health record users. And then it's just noteworthy that estimated payments increases for MDH and hospitals receiving the low volume adjustment are lower than other hospitals because these programs are ending December 31st, 2024. Congressional action is needed to extend them. And no, there aren't any slides for this particular policy update, but like I said, we'll send out all of this information so that you'll have it, along with like links to the CMS like final reports and proposed rules. So next I wanted to talk about the annual time burden on CAHs for new Medicare data collection. So this comments are due by October 7th. The CMS requests public input on the annual hourly burden for CAHs to collect and report data on OB services as proposed in the outpatient prospective payment system rule and on acute respiratory illnesses as finalized in the inpatient prospective payment system rule that I just talked about. This will be in the conditions of participation, so your COPs, in these rules include multiple information collection requirements that are one-time burdens for developing new policies, protocols, and ongoing reporting requirements, such as daily or biweekly reporting of respiratory illnesses, as well as maternal deaths. So again, I will send this out. The comments are due October 7th. Now for like the outpatient prospective payment system, this is the proposed rule. So those comments are going to be due on September 9th. And this is for policy changes and payment updates to Medicare's hospital outpatient prospective payment system, ambulatory surgical care center payment system, and other proposals that are affecting Medicare and Medicaid beneficiaries. So CMS is proposing a 2.6% payment increase for outpatient services provided by hospitals that meet those quality reporting requirements. And then there are also proposals to update the payments for intensive outpatient program services provided in outpatient departments and community mental health centers, to implement temporary additional payments for certain non-opioid treatments for pain relief, to make additional payment for the all-inclusive rate for certain high-cost drugs for beneficiaries receiving care at IHS, and to update measures in outpatient and rural emergency hospital quality reporting programs. This also includes some proposals that go beyond outpatient services, which are revisions to Medicare special enrollment period for formerly incarcerated individuals, additions to Medicaid and CHIP continuous eligibility requirements, and amendments to the Medicaid clinic services regulation that allows federal reimbursement for services furnished outside of the four walls of a freestanding clinic, and asking if, like, requesting comment on whether this policy should be extended to clinics in rural areas. So additional proposals and requests for information. I'm not going to go into all this because I know that I'm given a lot of information without slides, so apologies. But you might want to give some feedback on to CMS, would be like conditions of participation for obstetric services, and then a request for information regarding the safety of care measures in the overall hospital quality star ratings. Okay, so the last thing that I am going to talk about, two more things. I'm going to talk about two more things real quickly, which is the proposed updates to the Medicare physician fee schedule payments. And this, again, the comments are due September 9th. Proposals include payment for both in-person and virtual caregiver training services. They're permitting certain healthcare providers to provide virtual direct supervision to auxiliary personnel when required, a temporary extension of virtual supervision of residents by teaching physicians in certain cases, permitting opioid treatment programs to furnish periodic assessments using audio-only communications technology when the video is not available on a permanent basis. The return of statutory restrictions on geography, site of service, and practitioner type for non-behavioral health telehealth services. And this proposed rule also includes a bunch of updates and proposals that are applicable to rural health clinics. And some of those include allowing RHCs to bill for administration of Part B preventative vaccines at the time of service, rather than being reconciled at the end on the cost report. To continue to require provision of primary care services, but to no longer enforce primarily engaged in furnishing primary care services. It seeks comment on how to define mental diseases as it's related to the requirement that RHCs cannot be primarily engaged in the treatment of mental diseases, and to eliminate productivity standards. It also includes some updates to the quality payment program, the Medicare Shared Savings Program, and several other proposals affecting RHCs, including the removal of the lab for hemoglobin and hematocrit, and permitting RHCs to bill individual care management codes instead of just G0511. Okay, last one. CMS is finalizing a 4.2% payment update for skilled nursing facilities in their fiscal year 2025 final rule. And so on July 31st, CMS issued the skilled nursing facility prospective payment system payment rates final rule for 25. And this is going to become effective on October 1st of 2024. Any questions that I can possibly answer or get you an answer back from one of our subject matter experts?
All right, I don't hear any. If you have any questions for Lindsay, go ahead and drop them in the chat. Laura can make sure that Lindsay gets them if it's something that she's still here to answer, or we'll follow up with you. And again, she didn't mention that we'll follow up with the slides related to what she just updated us on. So thank you very much, Lindsay.
Thanks, Lindsay.
All right, Megan Lahr from the Flex Monitoring team.
Thanks, Nicole. One overall update from the FMT I want to mention, in the last month or so, we released a new policy brief on screening for health-related social needs, comparing CAHs to non-CAHs, and I'll drop that in the chat in just a minute. And we're also working on wrapping up several other projects from our last project year within the next month or so, so keep an eye out for those. And then really wanted to highlight today, for those of you who weren't on the call last week, or just as a reminder, the CAH Quality Inventory and Assessment is coming up. First, we will have an assessment office hour next week on September 5th at 3 o'clock Eastern. There won't be any content on the office hour, but feel free to come by and ask any questions you might have about the assessment. There's a recording we'll talk about in a minute that you can watch before that if you are a new Flex program coordinator or have not worked with the assessment before or have some questions. Feel free to watch that ahead of time. The assessment will open on September 16th. That's when the web link the portal will open up for folks to start submitting their answers, but feel free to start talking to your hospitals before then. That will close on the November 22nd, and so that is when all CAHs should complete the assessment. We can go to the next slide. And this has a bunch of resources for the assessment. The first link goes to a page that has resources for both CAHs and state flex programs. There's a CAH fact sheet, a full set of questions and instructions, both in a Word document and a PDF. The recording I was talking about with more information about the assessment, and the 2023 national report. And then there's also a page that has assessment resources just for state flex programs, and this has a state flex program fact sheet, the CAH email template that you can use to send out information starting on the 16th to your hospitals. And again, that link isn't live yet, that's in that email, so don't send that out until the 16th. But we really do encourage you to start reaching out to your hospitals, send them that assessment resources page link, some of these resources, encourage them to start looking. They can start collecting the information now if you want, if they'd like. If they have questions, if you have questions, reach out to us. But also just, you can also feel free to just, show up at the office hour next week. So that's all I've got.
Thanks, Megan. Any questions for Megan? Right. Again, feel free to put those questions in the chat for Megan and she can respond to them. Elena from Arkita.
Hi, everyone. A couple of quick updates from me regarding the CART tool. We previously mentioned there is a new sex assigned at birth data element change that will impact data submission starting with the Q3 2024 encounters for the medium time from ED arrival to ED departure measure, or OP18. The sex assigned at birth data element changed beginning with July 1, 2024 encounters, and will first be submitted for reporting with the February 2025 deadline for the Q3 2024 encounter. So QualityNet will release an updated version of CART to address the newest change. They don't have a date yet on when that will be. We've been getting a lot of questions from hospitals on when the new CART tool will be available. And at this point, it's just a wait and see when that will be released. But at this time, the CART version 1.24.0, which is currently out, that can be used for submitting the encounters for Q2 2024. And that data is due November 1st. 2024. So they'll still be able to use the CART version 1.24.0, and we'll let you all know when a new tool is released by QualityNet. Detailed information on that is available in the newsletter, and I can share a link with that in the chat. So hospitals should have seen that information come through the newsletter. The second update we have is we do have a new resource. We have the National Assistance to Address Social Drivers of Health tool. This tool contains nationwide resources to address social drivers of health and that are available in every state. Many of the organizations listed offer nationwide services or contain databases to identify local resources. So this tool can be used by hospital staff when a patient screened positive for a social driver of health, or it can be used by state flex programs as well. And the tools can be accessed by patients directly. We also have in that tool a little introduction of how hospitals can use that tool and what hospitals can do when they lack resources in their community to address social drivers of health. So I'll share that in chat as well. But definitely some good things to check out and be aware of to share with hospitals.
Thanks, Elena. Yeah. Any questions for Elena and Arkita? All right, go ahead and drop questions in the chat for her if you have them. Some super quick updates from TASC. We have our October Flex workshop coming up. That is October 22nd, 23rd, and 24th. And that will be out in Rockville, Maryland in the HRSA building. The request to participate form is open, so you can find the event on our website and a link to that form to request to participate. Otherwise, send myself or any of us on the TASC team an email and we'll help you find that if you need it. We have staff traveling in the next month or so. The NRHA Rural Health Conference and Critical Access Hospital Conference, which I believe is the week of September 24th. You might see Tracy, Terry, Sally, and Caleb at that event. So if you see them, please stop and say hello to them. NoSOR is coming up earlier in the month. So the annual NoSOR meeting, myself, Caroline, and Matt Bancroft will be at that one. So definitely come and talk to us as well. And then the last thing from TASC is we have a few new resources that we'll be putting out probably in the next month or so. So kind of keep your eye out for those, but we'll definitely talk more about them when they're actually ready. And that's it from TASC. If you have any questions for me, go ahead and drop them in the chat and one of us will answer those questions. Laura, I'm going to go ahead and turn it over to you.
Perfect. Thanks so much, Nicole. So now we're going to get to the topic of the hour. I am going to kick it over to Kristen Dillon here in just a second, but I'll kind of preview a couple of things just so everybody knows the order of operations of what we're going to do. So we're going to be talking about maternal care in critical access hospitals today. So we'll get kind of a state of the state a little bit on where things are, get some data shared from Dr. Dillon. And then we're going to have some brainstorming with some ideas that she has some really wonderful ideas on where you all can support critical access hospitals. I would encourage anybody who is a state flex coordinator on this call, or if you know someone, maybe you were invited by your flex program, that to reach out to your project officer if you want to talk through any of these ideas as they come up. I think with maternal care particularly, this is one of those things where we want to make sure that the money, the flex funding that we're using, because it is limited, is helping hospitals in the right way. And so the example I can give is that it is an allowable cost to do a service line assessment, but if you already know that your hospital has an 80% Medicare payer mix, a service line assessment for maternity care may not necessarily be the smartest use of funds. So we can brainstorm some other ways to do that. So just keep that in mind as you're listening to all of these ideas. And then after Dr. Dillon finishes everything up with her presentation, we're going to do some brainstorming and some discussing. We want to hear from you all at the state on what you're hearing, what you're seeing, and have some discussion between us. So with that, I am going to kick it over to our Chief Medical Officer, Dr. Kristen Dillon.
Thank you, Laura. Hi, everyone. So my name is Kristen Dillon. I'm a family physician. I have going on 30 years experience now working in rural communities. The first 20 years of my career included delivering babies, providing care throughout pregnancy and after. It was one of the favorite parts of my job, and clearly a crucial service for rural communities. And so something that we're really prioritizing, supporting, and we so appreciate the work that you do with America's rural hospitals, and anything that you all can help come up with to do what we can to address what's a very concerning situation, which I'll get into in a minute. So as you probably are aware, the Federal Office of Rural Health Policy is in the Health Resources and Services Administration, so HRSA, within Department of Health and Human Services. And that means that our whole HRSA agency really focuses on advancing health equity, improving access to care, and supporting the health workforce. And we are a piece of that, and that's why we ended up in HRSA with the Federal Office of Rural Health. We also have an advisory role across the whole Department of Health and Human Services. So helping to move this rural health work forward in all the other programs that the federal government's promoting. It also gives us a way and a real, one of the big important things I do in my job is actually to travel a lot and meet with lots of people, because one of the most important things we can do is to hear from you all, to hear from the hospitals and the communities you work with, and then bring that information back to the policymakers in DC. So across the Department of Health and Human Services, our work in maternal health is driven by a simple notion that no woman should die from pregnancy or giving birth. So what's the situation with outcomes for moms and babies in the US? It's actually not that good. The data that I'm going to share is from my colleagues at the Centers for Disease Control and Prevention, the CDC. There's two main sources of information about maternal death and injury. And this helped clarify for me why sometimes I felt like I'd see different numbers. I would have already learned something new would come out. We have a couple different reporting systems that are a little different in how they work and have different timelines. So one of them is the pregnancy mortality surveillance system, and the other is information collected through the maternal mortality review committees. And so I'll be reviewing information from both of those today. So pregnancy-related death is a death that occurs during pregnancy or within a year of the end of pregnancy from any cause related to or aggravated by the pregnancy. So the PMSS, the Pregnancy Mortality Surveillance System, reviews deaths that occur during pregnancy or up to a year after using death certificates and a few other linkages. So it collects information on pretty much every death in the US and gives us some of our national estimates as well as some basic information that can be pulled from those documents. The maternal mortality review commissions are operating in every state. They're largely funded through CDC. They are state-run committees that can provide a much deeper understanding of maternal deaths by understanding what contributed and developing and prioritizing recommendations that might reduce future deaths. And they use a lot of sources of information like vital records, medical records, social service records, mental health records, autopsy data, and in some cases they interview people involved in the care or family members. So MMRCs are multidisciplinary committees, and they have representation with diverse expertise to maximize the use of this broad array of information. So one of the things that MMRCs give us is they're not quite as complete. Every state does things a little different, and some deaths may be examined in more depth than others. They provide us, though, a lot of nuance and a lot of granularity in terms of like the story of what's going on, and in many ways help significantly with understanding how to respond, which is the kind of information clearly that we want you all to have. Okay, next slide. So here's some data. So first off, so this is PMSS. So this is death certificate data. And it shows the trends in pregnancy-related mortality ratios between 2000 and 2020. We have seen continued worsening over this time period. Some of this increase may be due to better detection of these deaths due to some changes in how they're documented. But there is absolutely an underlying rising trend as well. And in addition, we saw this very significant spike in 2020, and at least half of those deaths had COVID listed on the death certificate. So certainly had an impact there. What we see after 2020 was an additional rise in 21 that hasn't been released in this official data yet. And then the preliminary data show it coming back down in 22, but continuing the same trend. The overall trend, even if we edit out the COVID effect, is upwards. Next slide. So there's considerable racial and ethnic disparities in pregnancy-related mortality in the US. Using the 2019 data and then moving forward, we see continued rise in the death rates from for Native American, Alaska Indian, Alaska Native residents of the US, also Latinos and African Americans. The death rates, as you can see, are quite disparate across these racial and ethnic groups, and hold up across both rural and ethnic cuts, with in some cases it actually being additive. Next slide. So this slide looks at maternal pregnancy-related death rates connected to the location of residence of the mom. And what we see here, we were talking about the recent reclassification of rural. As you know, the federal government has like 14 ways of defining rural. Sorry, folks. Working different definitions for different purposes. But for these, the first four, large central metro, large fringe, medium metro, small metro, can be considered urban. And then rural are the two on the far right. And as we can see is that for the residents of the smallest rural areas, their death rate is nearly double that of the population with the lowest death rate, which is people living in suburban areas. Next slide. So that's some sort of bleak information. We see a continued upward trend. We far outpace any of our peer nations in terms of having relatively moderate to high income overall as a country. Our maternal death rates are far higher than any of our peer countries. So the next slides include data on about 1,000 pregnancy-related deaths that occurred between 2017 and 2019. And they were to the residents of these 36 states, which were the states that had the most complete reporting. And as you can see here, we're going to go over and look at what did we learn from our maternal mortality review commissions in terms of what's going on. Oh, that's very odd. It's supposed to be a map of US states. I don't know how we ended up with a world map here. Gremlins. All right, next slide. Sorry, guys. So the MMRCs in 36 states determined that with one or more reasonable changes to patient, family, provider, facility, system, or community factors, by changing one or more things, 84% of pregnancy-related deaths had some chance of being prevented. So if you take nothing else home from you today, that's what I'd like you to take home, which is the situation is not good, but folks who are looking at these deaths in detail see ways that we can change what's happening. Next slide. So here's something that I think goes against what we sometimes assume. We think a lot about a pregnancy-related death being something around birth. That's always like in the movies and the TV shows when everything falls apart, right? What we actually see from these reviews is 53% of pregnancy-related deaths, more than half, occurred between 1 week and 1 year after the end of the pregnancy. So these are not occurring right around the time of birth. They're occurring in the postpartum period, and they're a time when most individuals would have left the hospital and been back home again, and usually only receiving clinic-based care. Next slide. So what causes the deaths? The most frequent underlying causes among these pregnancy-related deaths are on this slide, and more than 80% of deaths were related to the following 7 categories. The number 1 category is mental health conditions. 23% of deaths were related to a mental health condition, most commonly suicide, and then either unintentional or unknown intent overdose or poisoning related to a substance use disorder. And then we have other causes related to bleeding, heart conditions, infection, blood clots, other kinds of heart disease, and high blood pressure. So again, we think about bleeding and strokes and high blood pressure, and those are crucial. They are treatable. There's a lot of work going on to help identify those both before and after, but during pregnancy and in the postpartum period. Another key takeaway for you, though, is anything you can do to help buttress the system of care for postpartum people in their communities for mental health conditions like depression and anxiety, and also for substance use disorders is crucial. We know that a lot of pregnant women are able to achieve abstinence from their substance use disorder during pregnancy, but that relapse postpartum is fairly common. And folks who have not been using are much more susceptible and at risk for overdose. So that's where good continuing treatment for opioid use disorder, the medication replacement, look at the upcoming FORP announcements for a new toolkit there. And widespread availability of Narcan can all really make a difference. Next slide. So this is a paper from Kathy Kozomanel and the colleagues at the University of Minnesota. Their objective was to look at associations between the number of births that a hospital does and severe maternal morbidity, which is the high-risk complications, which some of them are life-threatening, can lead to death, but it just casts a little bit wider net about the high-risk conditions that may be contributing to these deaths. And this study looked retrospectively, it looked back in time and linked birth certificates, death certificates, and patient discharge data from hospitals from 4 states. And this went from 2004 through 2020. So this is not a nationally representative sample, but it is a deep dive into a diversity of communities with a range of geography, socio-demographic characteristics, and healthcare systems. So next slide. So what they find. The results table focuses on the hospitals located in rural counties. And after they adjusted for clinical and patient characteristics, the risk ratios for both lower risk and higher risk patients were elevated at lower volume facilities compared to rural hospitals with more than 460 births a year. And for these patients, the risk of the severe complications more than doubled for patients giving birth at the lowest volume hospitals. The authors are very clear that they are not trying to make the case that low volume hospitals shouldn't exist. We know in many communities, the hospitals are pretty far apart. And it may be that these hospitals are providing a crucial service for a very large swath of geography. What we do know is that there's a lot of opportunity for quality improvement and safety improvement in these facilities, and also training and system development around risk stratification to ensure that folks who are higher risk have safe and good quality transfers of care to urban centers. Okay, so that's sort of the state of the state when it comes to pregnancy complications and pregnancy-related death in the US. The situation is very concerning. We have 1,000 or more women dying every year in the US due to pregnancy and giving birth, which is unacceptable. And there's something we can do about it. So let's go in and talk about what is it we could do to help try to respond to this and to try to help you all think about, as the helpers who help the hospitals, what could your role be in helping to address the situation? So next slide. So a few different things have happened coming out of our world. First, our office, the Federal Office of Rural Health Policy, did a project led by me and Christy Martinson, one of our senior advisors, that was a speaker series looking at, just a minute. A speaker series of webinars addressing the Birthing Friendly Hospital Initiative as just a foundational way to support hospitals, and then also pulling together information for hospitals that do not have birth units to help them achieve excellence in how they care for people who are pregnant, birthing, or postpartum. So if all the links are here on the slides, which you'll get, and if you're have some time, I strongly recommend going to watch the first webinar and the fourth. Those are going to give you the two overviews. But given that more than half of rural hospitals in the US do not operate a birth unit, there's a very important opportunity for us to ensure that the care is optimal at those sites, because there are still going to be people who are pregnant, birthing, and postpartum presenting there for care. The other thing that's been going on is related to the Health Resources and Services Administration, our larger agency, enhancing maternal health initiative that's going on throughout 2004. I'm looking to strengthen our maternal health work to address maternal mortality and related disparities in partnership with mothers, grantees, community organizations, and state and local health officials in these targeted states, which are the states where there was significant need of some sort identified, and in addition, where HRSA has programs that can make a significant impact. The other things that have happened from our Department of Health and Human Services is the continued progress of the Medicaid postpartum coverage expansion. A majority of states now cover women after they give birth for a full year, which is up from what used to be 6 weeks, can make a big difference in preventing deaths in that 1 year postpartum window. In addition, work with the National Governors Association around rural maternal health, an HHS initiative that is ongoing on preventing postpartum mortality. The Centers for Medicare and Medicaid Innovation have just released their Transforming Maternal Health model. So that's a CMMI model that states can currently apply for to make some really significant investments and changes in how they provide maternal health in their state. And then finally, coming out of our own Bureau of Health Workforce in HRSA, new funding for expanding training for nurse midwives and for doulas. Next slide. All right, I'm gonna put that back. Oh, I'm not seeing the slides anymore. I don't know if everyone else is, but it might just be my view.
Yeah, I can see them.
Okay, great.
Nicole, are
Okay,
you
great.
getting anything on tech issues, Nicole, or no?
Not that I'm aware of. Can everybody see them? Like, yes, in the chat would be great. Okay.
Great. Okay.
So we're on the advancing rural community health slide.
Great. Thank you.
Okay.
So our rural residency planning and development grants fund the creation of new rural physician residency programs in high need specialties that are financially sustainable beyond the period of grant funding. And in addition, we anticipate offering this year our rural network grants to help communities start to organize around any area or topic of concern, but certainly organizing care and the players around maternal health is an option with that. Okay, next slide. So the National Maternal Mental Health Hotline has just passed its 2nd birthday on Mother's Day this year. It has received tens of thousands of calls from pregnant, postpartum women, their families, and their care providers It's a 24/7 hotline. It has services readily available in dozens of languages. And if you go to the next slide, which is the promotional material, this is one thing that you could help push out to the rural hospitals that you work with, is ensuring that they know they can get this promotional material and have it available in their clinics and other settings, and to give out to patients. This is in addition to 988, which is the national mental health hotline number now. This one, though, focused and with special advice and services tuned to this stage of life. Next slide. So the next 3 slides are ideas and key resources. So the first is for hospitals without birth units. So this is information that you can use to educate yourself and then start to think about, what could I do with the hospitals in my state? And it's pulled from that webinar series that I mentioned to you. Next slide. So this next resource slide is for hospitals with birth units. Again, it comes from the webinar series and would let you familiarize yourself with the resources available. What is the work of getting better typically look like? Which for these facilities often includes ensuring they have a quality improvement program specifically related to their birth unit and their maternal care services, and engaging with their state's the Perinatal Quality Collaborative, which is related to those maternal mortality review commissions I was talking about. And then also starting to implement some of the care bundles and standard order sets, because we do have good evidence in high stakes care, like maternal care can be, as we've seen with emergency care and trauma. Having a plan for how to approach a situation and a plan for when are we going to deviate from that is a great way to build teamwork and safety. And especially in facilities where some of the scariest things may not happen all that often, it's great to have practiced and to have a plan before things start flaring up. So then finally, resources and ideas for hospitals that may continue to operate clinics that provide prenatal and postpartum care. This is another place where you can really
Hey,
help.
Nicole, can you go to the next slide real quick?
Oh,
Thank
thanks.
you. Sorry, continue, Dr.
Perfect. This is a place where you all as flex programs can really help clinics and across the state, especially as birth units are closing or in places where they're pretty few and far between. Anything that we can do to get the outpatient component of care back into the community, so those prenatal visits and the postpartum visits, that can be 8 or 10 or 12 visits over the course of a pregnancy that really don't need anything more than a basic clinic setup. If we can get those back in community, make them more accessible, support people in accessing that care, it really helps them be healthier, even if they need to make a fairly long trip to get to the hospital for birth or when other services are needed. Okay, next slide. So here's some ideas for how US Flex programs could support rural maternal health care initiatives. We can come back to this for the discussion. Certainly doing statewide work, creating or reinforcing any networks of care and referral, feasibility studies, and also anything that can happen around centralized training for both simulation or distance learning CME for clinicians are all solutions we've seen across the country that have rolled out at like a regional or a state level and been really effective as a result. So we're going to move on through and then we'll come back to that. So the next one, this should be old hat to you all by now, but in terms of resourcing any of this rural work we do, 3RNet for recruiting, retention, and supporting particularly small hospitals with the new augmented services that 3RNet has rolled out. They can be sort of an outsourced recruiting firm now in terms of the way that they can help a small facility coordinate their applicants and prospective recruits. And then, as usual, our research center's website and the RHI Hub information. So we can go to the next slide because I don't know, we always have to have it in, but We love to hear from you, but you all know how to get a hold of us, I think. So I think that one's probably moot at this point, but can't get a slide deck through clearance without having that in. All
Dr.
right.
Dillon, there's a question. There's a question in the chat, and I don't know if we happen to know this answer. It's a data question.
Okay.
If we happen to know the difference in mortality rates between rural hospitals that have birth units and those that don't.
I have seen early information that is very concerning about the maternal outcomes in communities that, for the residents who live in communities without birth units. So yes, we are starting to see that it is, we know it is more dangerous if you live in a rural area, period, to be pregnant or give birth. And it appears that we're starting to see a trend that's even worse when folks are really far from a birth unit, but that's still sort of preliminary information at this point.
Twice.
So you want to go
Gotcha.
back, Laura,
If we want to go back,
the question slides, or I don't know, how do
yeah,
you want?
yeah, I was going to say the same thing.
Part. I've got 10 minutes or so till I need to run.
Yeah, well, let's go back a couple more slides, Nicole, to the one about hospitals that have birth units. One more. Oh, wait, one more. Sorry about that. This one. I actually realized I put this on the one without birth units, but should have put it in the one with birth units. And this might answer your question, Jill, that you put in the chat about low volume hospitals that deliver babies and lack deliveries to keep their competencies up. How can they keep their skills up? And so one of the ways we can talk about that is the simulation trainings that are listed down at the bottom. I can talk a little bit more about Minnesota if you, Dr. Dillon, maybe want to talk about Laerdal as an option.
Mm-hmm. Sure.
Can I just add a comment to that?
Yeah.
How do they get to the simulation centers? Is it online? And I know this was an issue for Hopi Healthcare Center, which is on the Hopi Reservation, and they were always asking us how to keep their competencies up, but they have since closed their birthing facilities, but the women don't want to go anywhere else and do show up in their ERs to deliver the babies.
Yeah. Thanks for raising that. In this work that we're doing, we've been seeing two different things that are, I think, really helpful. One is sort of distance learning, CME, continuing medical education for physicians, nurse midwives, PAs, NPs, nurses, anyone else working in hospitals. Illinois has just rolled out a statewide program for hospitals without birth units to be sure that those staff in the rest of the hospital are really trained up well. They expressed some willingness at some point to even expand it further, but they're just because they're in the process of a statewide rollout. So there's like that cognitive skills around a healthy looking 32-year-old woman who's anxious, who just gave birth 2 months ago, may have lungs full of blood clots and not just be an anxious 32-year-old woman. And so helping clinicians just change their framing of how they think about pregnant and postpartum folks and be a little more comfortable with it too. So there's that piece of it. And then the other piece is simulation, and simulations are by far the best if they happen on site, because then having been through this myself, you're doing it in your rooms, you're going to your crash cart and realizing what isn't in it. You are running down the hall to your lab to see how long it takes. You're doing all the things right in the place where you're going to do it and with your whole team, and it saves a lot of travel time. So one of the options, again, we're seeing in certain states, either a state university, a state medical school, various different entities stand up a centralized simulation like leader team with the equipment and the mannequins and whatnot, and then they travel around and go to different sites to do the on-site training with the teams in their facilities. So we're seeing it set up in a range of ways. And then the other thing we're aware of is Laerdal, the manufacturer of a whole bunch of the equipment that we use around birth and neonatals resuscitation, has a service that can be hired to come out and put on simulations, again, doing it on site. And we've talked about the fact that that's the type of service that flex funds could be used to support because it is, educational and quality improvement for the hospitals that participate. How'd I do, Laura?
Did great.
Okay.
And I'll tag onto this a little bit. And I think if Emma Distel's on the phone from Minnesota, she can chime in if I say anything wrong. So the reason why I wanted to have Dr. Dillon talk about the contracting option for this is because purchasing the simulator equipment itself is very expensive. And Emma Distel will be the first person to tell you they have a critical access hospital in Minnesota who was able to purchase a simulator, but Flex can't pay for that because of the cost. It is considered equipment. However, they were able to reach out and get Blue Cross and Blue Shield of Minnesota to purchase that. And so someone else put up the big capital cost to buy the simulator. Flex is supporting a lot of the training, and that critical access hospital is now having other hospitals come in and do the training on the simulator at their site. So you know that we say this all the time. We love braiding funds. We love finding other sources that can pick up where we can't. So if that is an option in your state where you are able to, oh, Emma just messaged me, it's mobile, it can go other places. So this is exciting. It can go and reach out. I know that was one thing they were working on when I visited that hospital, to get it to go to fire stations and EMS agencies and get them to train on it too. So if you have an option like that in your state, to either reach out to a private pay insurance company or a philanthropy fund or anything where you can find another source of funding, great, use it. Let's braid some funds and figure out where we can work together.
Wonderful.
Yeah. Do you happen to know offhand, Dr. Dillon, how expensive the Laerdal training and education is, or does it vary kind
I'm
of
sorry, I
by
don't.
situation? Okay.
Yeah, I don't. That maybe that's something we could get in follow-up, would be at least
Yeah,
arrange or something from
absolutely.
them. I know, and this is why it'd be so great if Flex programs can help, because I know one of the things I said is it's a lot more affordable if they can come do multiple facilities, within driving distance
Yeah.
of each other on the same trip. Because they're coming out of
Yeah.
somewhere centralized nationally. So this is where that so much of this work, the Flex programs have an incredible platform because of the way you can network and get some economies of scale in rolling these out to facilities.
Mhm. Yeah, absolutely. And I think, as you mentioned, anything we can scale up to a health system, we can do some cost sharing, or even, I think you mentioned this earlier, looking at medical schools that maybe have simulators as well, right? Is that an option?
Yeah, it just varies by state. It seems to be who's got the equipment and sort of doing the work. I'm familiar with it coming out of a centralized part of a health system sometimes, medical university, or other sorts of like state government, different offices within state government potentially doing it. You just, every state solves these problems differently, has different capacity in different programs or offices or institutions. And so it's just a matter of figuring out in your state who's the best one to do it.
Perfect. Well, there's a couple of things here. Within the last couple of minutes that we may I may call on a couple of folks in the chat to chime in when we do this discussion, but are there any last minute questions specifically for Dr. Dillon before she has to leave in 3 minutes? Feel free to come off mute if you want to.
There's a question in the chat from Mary Powell. Do we have information about Flex working with SAMHSA on women's set aside block grant for mental health, substance use disorder, given the graphic data on mental health related postpartum deaths?
I don't have any information on that happening yet, but that is not to say that it can't. Depending on, we always say this, it depends on what Flex is paying for. So Mary, because we need to talk later this week, we have a call set up already. Let's talk.
That's a great idea.
Yeah.
So I'm assuming all these links are in the presentation for us to click on for especially the ECHO project and the resources. Okay,
Yes,
they are.
good.
Mhm.
Good. Thank
Oh,
you.
and thank you for picking up mentioning the ECHO project. So that's operated by the Indian Health Service. It is free and open to any clinician in the US. They have made it available nationwide. So that's an issue where it's not anything you all have to get going. It's just something you can promote. But it is specifically tailored for maternity care in rural and remote situations.
Perfect. Okay, well, in
right.
that case, Dr. Dillon, we'll let you go. The rest of us will stick around. We have a whole nother half hour we can do a facilitated discussion. I've got some questions I want to throw out at folks. If anybody has anything they want to ask Dr. Dillon in the future, please send me an email and I can pass it along to her. Thank you again.
Okay. Bye, everyone. So great to be with you.
Thanks. Okay. Can I keep on going on our simulator question that we were talking about before? Emma, are you on the call now? Do you have anything you want to add about simulator projects? And then I know Leslie in Montana says they also have simulators. We can chat about that too.
I don't know if I have anything to add because I missed everything that you might have talked about. Apparently, I'm just a blue screen on my video.
I basically just said that, the point made that buying a simulator is expensive. And if we can braid funding from other sources, that's a great idea.
Yeah, and I think that there's two different options. Our simulator, the simulator in Minnesota that you were referencing is really expensive because it's high fidelity simulation. There are lower fidelity simulation options that are a little bit more reasonable or budget amenable. Not saying that Flex would pay for them, but it is a cheaper option. And I think that there's also the perinatal quality collaboratives across the country too have had some really innovative ideas with simulators. We met with Iowa when we were starting this project, and they have what they call like simulations in a box. And so it's every hospital gets, the supplies necessary to simulate postpartum hemorrhage or hemorrhage things. And so there are a lot of, you don't necessarily have to have this giant expensive mannequin that automatically pushes a baby out in order to have a simulator and call it a simulation and get a high quality training out of it.
That's a very, very good point. Leslie, do you want to tell us what kind of simulators you're working with in Montana?
Hey there.
Hi.
We have the high fidelity mannequins here. We have what it's called Sim Montana, which is simulation in motion. It was done by a grant, Helmsley maybe grant. And we utilize them through Flex to do training. They have it's a big truck. Half of it's an emergency room, half of it is an ambulance. And they can practice, they do training on birth and a variety of other things. But it's very real. They can make the mannequins do all kinds of things. And the hospital staff have said it's been very beneficial for them to take that training.
Great. Thank you. Okay. Nicole, do you want to keep going on our discussion here?
Yeah, let's do that. You want me to throw out the first question that we were? Okay,
Go for it.
Okay, what are some of the challenges and barriers you all are seeing in your state? Feel free to unmute your mic, turn your camera on if you like, or don't, but unmute your mic. You can put it in the chat. We might ask you to expand upon it, but.
Do you want to stop sharing the slides right now, Nicole, so we can facilitate the discussion easier? Would that help?
Sure.
Jill, I see you chimed in. Arizona has OB deserts. Can you expand on that a little bit?
We have 2 counties, and Arizona only has 15 counties and they're huge. 2 of which don't have any OB services at all. So they don't have any delivery, any prenatal care. So I love the simulation trucks. And I know that, we've got College of Medicine right here on our campus, and they have an amazing simulation trainings, but I don't know, it would be neat to see if they could go remote.
Leslie Howe commented that many small hospitals are not doing birthing now, so Montana may have the most maternity deserts. And Nancy Joe also commented that Nebraska has or possibly had sim trucks, but they're very expensive to maintain, and no agency has agreed to be responsible for maintaining that.
And one of the things that Dr. Dillon mentioned as a possible idea, this isn't a simulator, so to speak, but one of the things that Flex does pay for well and happens a lot is continuing education, right? So if you've got a hospital that does not have a birthing unit, but there's probably babies still being born in that emergency room, right? You can send that emergency room doctor over to some kind of a continuing education that can fall under patient safety, quality, something, right? We can make that, talk to your project officer, but we can kind of start with that and then figure out what are we going to look at afterwards? Are we going to see safe birth rates, things like that in that hospital? So that is an option as well.
I remember visiting the critical access hospital in Moab a few years ago, and the CEO, I think it was telling us how he sent his staff, they did rotations in bigger hospitals that had higher levels of births. So they would kind of rotate their staff in and out on a fairly regular interval so that they would get that practice to be able to maintain that birthing unit, because if they didn't, it would be a 6-hour drive in any direction for people way out there in that service area to still have that kind of service.
Yeah.
There's a
Sarah,
comment.
do you want to chime in and tell us what's going on in Arkansas?
Hey, so just since I started with the Flex program in October, I think the first alert that we had came in November, and we've since had 2 more from our critical access hospitals saying that they have had to close all OB services because it just wasn't lucrative for them. They were hemorrhaging money trying to keep those open, and it just was not feasible for them. We've had at least 2 conversions in addition to those 2 REH facilities, both of which closed, all of their services that were not just for emergency. So, like I said, it's terrifying to think that our most recent needs assessments and all of our surveys came out to show us, ranking 46th in the US for maternal care and maternal mortality. So I'm really anxious to see how this shakes out in the coming year or so. But we've been in talks with some of those hospitals and trying to figure out, okay, how can we support you through this process? Where are your patients going? Are you helping them to find care? How can we bolster those efforts? And thus far, let's see which of those hospitals. It was somewhere in Northwest Arkansas. They've coordinated with several other critical access hospitals or doctors' offices within several counties to say, okay, here are your hot spots for, where we can send you. How can we make sure that you can get out to these areas? So some of those have been able to provide transportation. Others have had some success with, oh goodness, I'm losing my words. Others have had some success with telehealth for, just the in-between visits. But that's where we are right now.
Mary, I see you came on camera. Do you have something you want to add? And then I'll throw in something on some financial assessments here after we hear from Mary. Mary, if you're talking, we can't hear you.
There, can you hear me
There
now?
you go. Yep.
So I'm on the maternal health task force that we have interdepartmental and across state. And I think I think this is a fantastic presentation today, because I think what I heard that is reinforcing, and I'm going to take back, is we could get all hung up on the delivery, and that's really important, but the prenatal and the postnatal care seems to be super critical. And that was a discussion we had at our maternal health task force, was how do you deal with the hospitals who simply can't deliver because financially and the population, they can't support it. And so we had one close, but they partnered with another CAH, and they're doing the OB is at the hospital that closed doing all the prenatal there and all the postpartum there, but you have to go to the delivery hospital where you have that trained nursing staff and the OBs who are delivering enough volume. And so rather than get terribly hung up on that, albeit important delivery piece, teaching that what we've been discussing is teaching the patients how they're going to have to engage in this system, and it's not optimal and it's not magic dream baby delivering, but what is that safest model we can promote to patients and deliver in collaborative way. And I just think that it's a little bit reassuring that despite the problems that were presented here, that model that they're moving towards seems to be in the northern part of our state, seems to be probably a great long-term solution and less of a crisis response.
Yeah. Well, I'll throw out something here for Sarah's point on some of the financial things on this. I mentioned it earlier where Flex can pay for financial assessments, service line assessments. And the context when I mentioned it earlier was about adding a new service line potentially, right? And this idea that if you know that your hospital has an 80% Medicare payer mix, adding labor and delivery as a service line is probably not going to give you the money that you need, right? The other side of that though, is that you could talk to your project officer so we know what's going on, but like you could also run a financial assessment to confirm that labor and delivery might be the problem, right? Where Sarah was mentioning they're hemorrhaging money. A financial assessment could actually confirm if that is the case, or if the money may be coming out somewhere else. And you can kind of figure out, is it taking away labor and delivery? Maybe it's taking away a different service line. Maybe it's keeping one of them in, and more about right sizing with the services that your hospital is providing, right? So it could also be the other side of that coin. Nicole, what's our next question to hear about from folks?
Identify and discuss state initiatives that your state Office of Rural Health and or Flex program are currently doing to support and address maternal health needs. So what do you guys have going on in your state offices of rural health and Flex programs? Lindy.
I can never find that hand thing, you know. So
That's all right. We'll see you if you come on your camera.
We're doing some really interesting things. It's a little too involved for a complete discussion, but if anybody wants to reach out. But we have three things where, because it's a big issue, safe deliveries. We had 3 critical access hospitals close their OB. One just reopened, one's thinking about reopening. You know, it's like musical chairs out there, you know, with the CEOs. We just had 3 CEOs change seats. So, you know, it's a really big issue. So we're hitting it 3 ways. One, we have an internal work group that we're meeting with our maternal child care division at Department of Health. And we call it the Safe Deliveries Work Group. We're talking about simulators, what's going on out there, different work groups. We have the Rural Collaborative, which is about 20 of our critical access hospitals are members of. We have the Washington State Hospital Association as a member, and then our State Office of Rural Health. And so we meet every other week, and it's slowed down a little bit this summer. But one of the big things that came out of that is that we have a Northwest Rural Health Conference, and everybody's got a rural health conference that their state either participates in or is a part of. And we had an intensive last year, 3 hours on the Monday morning before the conference starts. We leave that morning open for intensives. And
Hi, Sandra. My name is Jack King. I stayed in your hotel first week in August, and I had a meeting there, and we rented the room.
Sorry. Sorry,
Okay.
Lindy, keep going.
I thought maybe he had come to our conference. I was kind of excited because it's a nice hotel. So we invited all and one of the things we do with our flex money is we offer scholarships, and then we promote these kind of work groups that are come together. Luckily, we had somebody else, Grant, that popped in and helped fund part of it, but we did offer scholarships to the RNs that came to the group, and we got a lot out of it. It was a listening session for all the leadership in the state, but was also a way for all these nurses to connect. And they started talking about their challenges and their resources. And now we have this simulator project that is starting, and the hospital is opening up their simulator for other nurses to come in from other hospitals, and, you know, just starting a schedule. It was kind of cool to hear. And so we're going to do it again we got so much out of it. We're going to do it again in March next year. And then the other group that I sit on is the National Governors Association. And we're one of those states that is part of that group. We're interviewing for, Pat Justice, retired. And so we're down to 2 candidates today. So we'll see. We hope to get somebody on by next month. And then he will be involved with this group. But they're meeting back in DC on October 24th with all the states talking about it. So that's another way that we're involved. We're at one of the states that the governor's changing next year. They're open, they're up for election. And so the policy director from the governor's office is leading the little work group that is part of the big national governors group. And so we have 2 meetings going on at the same time, but we're trying to set the policy for the next governor so that he can just take it and run with it. So, there's a lot more detail than that. I'm happy to share lots of stuff, but that's what we're doing and ways that we're using our flex money. And I thought the workshop, the intensive, was an amazing event. And I think I even have notes and an agenda I can share. So.
Nice. Thanks, Lindy.
Emma dropped something in the chat. A CAH in Minnesota is looking for examples from other states that have closed OB and then reopened the service. If anyone has hospitals in their state that have done this, reach out to Emma. Does anybody know of anywhere that's happened? Any states that's happened in? If not, Emma, we'll keep doing some research and we can figure out if that has ever happened.
Okay. Any other initiatives going on in state offices or flex programs? Things already happening.
And it does not have to be simulator projects. I think the last few states have all had those and I'm so excited by them. But if there's other things going on, please.
Okay, Lindy and Emma can connect. Looks like Lindy has some examples of that. Okay, how about if you think of anything, drop it in the chat. Our next question. Oh, hi, Jeannie.
Hi, yeah, I just wanted, it's not directly that, but just to share a little bit of a success story. I just recently had an opportunity to do a site visit at a hospital in Alaska. I'm with the Alaska Hospital and Healthcare Association, and this is in Utqiagvik, or formerly known as Barrow, which is the northernmost city in the United States. And there's a critical access hospital there that's run by a tribe. And they have actually been expanding their capacity to be able to do emergency C-sections. They do deliveries, but obviously haven't been able to do C-sections, and they are expanding their capacity to handle OB. Rather than decreasing it, even though they have very low volume. They have right now 40 deliveries a year, but they are looking at what's preventing women from delivering there and how can they add those services in. And one of the key things was the not being able to offer epidurals for pain management. So they are gearing up so they can offer that service to women who want to stay close to home and deliver. And they're in an area of the state with a young population and, you know, quite a few women. But it was just very inspirational to see that a facility can put their mind to it to add back in OB services. They recently successfully did an emergency C-section, not because they wanted to, but because they felt there was no other option. And both the baby and mom were fine, didn't even have to be medevaced out to a larger facility.
Wow.
So really encouraging to see that what
That's
can be
amazing.
done. Yeah, it was pretty amazing to see what they're doing. And that's at one of the most remote places in the country. So.
Oh. Okay. How about, are you, and think about what's going on in your states. Are there initiatives related to this that you can get involved in? We've heard more than one person say that they sit on a steering committee of some sort about it, but what else is going on in your states that your Flex program might be able to collaborate with?
You can also say that my idea that I have right now is to find out if there is a steering committee that I can sit on. That is a perfectly acceptable answer.
Yeah, it might be something to just walk away with at the end of this webinar. Think about what else might be going on. And if you're not sure, maybe do a little research and see what you can find. So did anything you heard on this webinar today spark something for you? Something you might want to do, something you might want to look into, someone you might want to talk to? Come on, guys, someone please say yes. There had to have been something inspirational here.
We did, Nicole. Emma and Lindy are going to talk to each other.
Yeah, yeah. And we could talk to Jeannie.
I'm super excited about that phone line and the resources because I did not know about those.
Great. I thought the idea, thinking of SIM training as something that maybe 5 of your hospitals are interested in and getting a better price for it was a really good point, something to think about. And you know, if you have 1, you have 5. I don't know how expensive that is or how it fits into the financials of work plans, but I thought that was a really good point.
This is Joyce. I mean, one of the things that I know probably our hospitals are doing in the ER is delivering babies, but I personally can't say who's doing that. And so being able to, for Jill and I to reach out directly to the ER departments and really find out what they're doing and how maybe we can help them because EMS is bringing those people or people are just showing up to have their babies. And really having a better handle on what is actually happening at our 17 critical access hospitals with EMS and the ER. So that's something that hit me about, well, what can we do? Because those are things that we work on. EMS is a big deal. And so are our ERs. So anyway, so Jill and I will talk about that.
Yeah, I thought that was a great kind of almost quiet point that Megan made in the chat, that your hospitals may not be intending to deliver babies, but they probably are in their emergency rooms.
Well, yes, and we know, I think at Benson Hospital, they have a corner. They've set something up because they're ready. They have to be ready in the ER because they see it, right?
Right.
So, but I can't personally say I know what happens. And I think that would be something very useful for the Arizona 17 hospitals for us to have sort of a profile of what do they do and what could we help? What could we help with?
Yeah.
Well, and I know for a fact that Hopi Healthcare, that they don't want to leave their community and they're delivering the babies in the ER.
And the point about, knowing any kind of statistics, and if we're going to do anything with the flex funds on that, to be able to you know, have simple tracking of something or whatever. But anyway, thank you.
Yeah. And it's part of EMTALA, right? I think EMTALA
Sure,
specifically talks about emergency rooms not being able to turn women away that are in labor.
That's it. They can't turn them away. No, and they're
Right.
doing it. I mean, they're doing it, but we don't know. So where are those statistics? Where do you get those statistics? So the ER probably has them, but you know, getting somebody to pull the numbers and all that, I mean, they're just inundated. And so, but it's a fair point. And I thought the doctor just did an exceptional job in looking at those statistics, and it says it, the data says itself, something has to be done here.
Yeah. And there may be data, EMS data. You brought up EMS. If your state is requiring any kind of data entry for NEMSIS and that sort of thing, you might have some access to data through NEMSIS. I'm not sure exactly what those data elements are off the top of my head, but that's something to check out.
Nicole, great point. And we have a close connection to our Bureau of EMS and Trauma. They're wonderful.
Yeah, and each state has data managers that you can reach out to help you figure that out. You don't need to go to NEMSIS and try to dig through that data.
And we have a very close connection. So great point. Thank you.
Yeah, you bet. Mary, go ahead.
Okay, so I have officially learned something big today, which is we got to focus on the prenatal and the postnatal care, which means if you're going to run some data, what subsequent to what you were just talking about being born in the ER, I would like to see of the people who are delivering in the ER, how many haven't had much prenatal care. I know that's often an issue, but I only know that anecdotally. So if we have some future data sets that we can look at, I think that's a really important thing. So again, it's the patients that aren't being engaged in care. It's the patients who don't know how to find care in one way or another. And so if there are emergency cases, is it because we're missing them before that moment?
Right, and then the postnatal care too, if they're.
Yeah.
Yeah, yep. I'm gonna have them all go ahead and launch our post polling questions, but we can keep talking. I just want you to be aware the thing is gonna pop up. Please take those questions, but definitely continue talking. We've got 5 more minutes. Go ahead, Lindy.
So I just thought of something that, you know, it's always the staffing issues, and that we learned from our work group and the intensive. You know, when you're losing OB nurses all the time, because OB nurses do not want to work when you only have 2 or 3 babies a month or a week or whatever. You know, they want to go to a high productive producing, you know, OB hospital. So they tend to leave. So one of the things one of the hospitals did was they were trying to figure out, okay, midwives, how can we expand other people's roles? OB nurses don't want to do clinical work. They want to be labor and deliver. So how can you expand midwives and some other roles? And so what they discovered was the medical staff rules in their critical access hospitals, 2 or 3 of them, restrict the medical scope of the midwives. And so they hired Chartis, and it was a little bit spendy. We didn't get involved in this one, although we may help another hospital if they can't find the funds. And they completely rewrote their bylaws, their medical staff bylaws, and now they can use midwives in their labor and delivery rooms. So that's something I just wanted to share. That was an aha moment for me.
Huh.
There's a great question in the chat that we can answer in the last couple of minutes, and I don't know if anyone from the TASC side wants to chime in, or maybe Megan is somebody who can develop surveys. If we were to develop a survey/needs assessment of sorts for something like this, what form could that take without leading to something as lengthy as, say, the CAH quality infrastructure assessment? Or might that be included in the future? Are there ways to do some kind of survey creation that's not super lengthy? Megan came on camera, so I think she has ideas.
Well, I would just say a couple things. If there are examples of questions that would be helpful to put on the CAH assessment, if there are just one or two questions that you think would be really helpful to know from all CAHs in the future related to maternal health, I think that's something we'd always be open to. But as far as doing your own, you can always, I think, come up with simple things, and it's trying to figure out what would be helpful, or even working with other state flex programs to say, have you done anything like this, or have your SOARs done anything, or I think at the state level there are lots of folks that have probably done something similar, or hospital associations, and so maybe it's asking around too for what have folks already done, just to get those types of things. But I think always, trying to get a survey of your cause can always work, but I think some of those things, what are the most important data points to start with, and making sure, I think what we always try to do is that you're able to get to the people who are readily available to answer those types of questions when you're developing a survey. But as far as the assessment, if there's something that we could add there, we're always happy to think through that too.
Yeah, and I'll make another point. This kind of repeats what I was saying before, but before developing a whole survey and needs assessment, it might be helpful, like Megan said, to find the initial data points that you might need. Like if you can figure out from any other existing data sources, your hospital associations may have this on how many births are your hospitals reporting, right, in the claims data. Or even if it's like community demographic data. Like I said, if you know that your hospital has an 80% is full of 80% of people who are paying with Medicare, they're probably not delivering babies, right? So starting with that information can kind of take things down a little bit to figure out either one, who you need to ask for more data, or what other questions you may need to ask. We have 1 minute left before we let everybody go. Is there anything, Lindy, our governor's office is leading the work group designing a survey and assessment. She'll know more later. Okay, so Sarah, reach out to Lindy. But yeah, if there's other resources or ideas or questions you have, I can always send questions back to Dr. Dillon if they're clinical. We can always talk to TASC about more resources if we need them.
Another thing too, if you're aware of resources like Lindy, once that is done and available publicly, post it in the forum as some new resource that you're aware of. A lot of people get notifications from the forum and we'll see a post like that. So if not, we can always draw attention to it in other ways, but the forum is a great way to share that kind of thing. All right, I think we are pretty much at time. So thank you everybody for attending TASC 90 today. Thank you for the fantastic discussion, answering questions, throwing your ideas out there, talking about what's going on in your state. That's absolutely how you all learn best. And I know that you guys like to hear that sort of thing from each other. So Laura, nice work on this webinar. Dr. Dillon's presentation was great. So thank you everybody, and let us know if you have any follow-up questions.
Thanks everyone.